Shall we start now? Autologous blood transfusion is the collection of blood from a single patient and retransfusion back to the same patient when required. This is in contrast to the allogenic blood transfusion, where blood from unrelated anonymous donor is transfused to the recipient. What is the use of autologous? Have you people heard of bone marrow transplant? Bone marrow transplant. That is again of two types, autologous and allogeneic. Now, what are the different methods of the autologous transfusion? Is it safe? Is it safe as compared to the allogenic transfusion? It is safe. Okay. When it is safe and why we are going for the allogenic transfusion? Why autologous is required?
Before surgery, we collect the blood, or during surgery, blood is not given.
Okay, one reason. What else? If you want to say that to prevent the loss of blood, to prevent the wastage of blood, we can collect from the same patient and retransfuse during the surgery. Okay. Or last to last class we have discussed about the rare blood groups, right? In those cases also, जब blood group compatibility match नहीं होती है and the surgery is planned, then the doctor plan for the autologous. Now the different methods for the autologous transfusion are cell salvage, preoperative autologous donation, and acute normovolemic hemodilution. Although in our blood center we are not following the policy of autologous blood transfusion. In cell salvage, what we do is blood is collected from suction, surgical drains, or both and retransfused back to the patient after filtration or washing. In preoperative, just ask them to leave the class. Those who want to leave the class, they can. Preoperative autologous donation, blood is collected in advance of an elective procedure, stored in the blood bank and transfused back to the patient when it is required. In acute normovolemic hemodilution, blood is collected immediately prior to the surgery and blood volume restored by crystalloids or colloids. The blood is then retransfused towards the end of the surgery once hemostasis is achieved. Now the advantages and disadvantages of the autologous. What can be the advantages? Obviously, reactions कम होगी, transfusion transmitted infections होने के chances बिल्कुल nil हैं, right? Because you are giving the same blood to the same person. What else? Reactions which occurs due to antibodies, वो नहीं होंगी. What else? What else? Have you ever heard of those people who refuse to take the blood from other people? कभी सुना है ऐसा? कभी कोई लिटरेचर पढ़ा है? It's written. They refuse to take. In that case, they go for the autologous transfusion. Now there can be the disadvantages also. Cost pressures may require capital expenditure, increased use of disposable and the staff training. Because when you collect the blood from the same person, you have to filter that blood, you have to wash those RBCs and then you have to retransfuse to the patient. Complex logistics for collection, storage. Complex logistics for collection, storage, and transfusion of the correct unit to the appropriate patient may increase the potential for the clerical error. This can be possible because in OT, supposedly 2-3 OTs are going at a time and you are doing the autologous collection for the two patients, then there are higher chances of clerical error. Unused blood is wasted and cannot be returned to the donor pool.
Stopping that second move. Please stop it, otherwise will be thrown out of the class. The second warning.
Then there is an increased risk of bacterial contamination. Why there will be a wastage of the blood? You have collected, then why you collected the blood? To balance the volume of the body also, right? Sometimes during the surgery the patient is not able to recover. The patient expires. Then you can't do anything with that blood. You can't return that blood to the blood centers. And then there is an increased risk of the bacterial contamination. Because in the blood centers you keep all the products at different temperatures. But in OT, what can happen? 4 घंटे हो गए, 5 घंटे हो गए, collection हो गया, but you have not transfused back to the patient. Then in that case, there are the chances of reactions to the patient. Now, what is cell salvage? This technique can be performed intraoperatively, postoperatively, or by both ways. The process involves collection of shed blood from the surgical field. The salvaged blood is then either filtered or washed and then processed prior to retransfusion back to the patient in the immediate post-operative period. The blood generated is labeled and kept with the patient at all times and is not refrigerated. क्यों नहीं रेफ्रिजरेट करेंगे उसको? लास्ट टू लास्ट क्लास में जब हमने कंपोनेंट्स प्रिपरेशन पढ़ा था तब हमने कुछ बताया था. कंपोनेंट्स कितनी देर में प्रिपेयर होनी चाहिए आफ्टर द कलेक्शन ऑफ ब्लड? किसके हिसाब से? सॉरी, खड़े होके बताओ क्या बोल रहे हो. बताओ, हो सकता है सही बोल रहे हो. विदिन 6 आवर्स आपको कंपोनेंट प्रिपरेशन करना होता है. वाई 6 आवर्स? कोई भी एक खड़ा होके बताओ. प्लेटलेट्स का क्या इशू रहता है? अच्छा, और अच्छा, और अगर प्लेटलेट्स बनानी ही नहीं है तो? होल ब्लड कलेक्शन हुआ, PRBC कलेक्ट सेपरेट कर दिया, FFP सेपरेट कर दिया, प्लेटलेट्स को भी नहीं सेपरेट करा तो भी 6 घंटे क्यों? WBC तो मैंने ल्यूकोडेस्टिक फैक्ट के लिए है, तो WBC का तो कोई इशू ही नहीं है. There are chances of bacterial contamination and alteration in the pH of the collected blood. ठीक है? Preoperative autologous donation. This process commences up to 5 weeks prior to the surgery, allowing the collection of up to 4 units of the blood. In that case, oral or IV iron supplementation may be required to maintain the erythropoiesis. The last donation should take place at least 48 to 72 hours before surgery to allow for the equilibrium of blood volume. The blood is collected into citrated phosphate dextrose blood bags and stored in the blood bank in the conventional manner. It should be clearly labeled to identify it from the allogenic units. At the time of surgery, the pre-donated blood is drawn from the blood bank as required in the conventional manner. क्यों प्री-ऑपरेटिव ऑटोलोगस प्लान किया जाता है? See, cell salvage is a technique जो आप बहुत emergency में use करते हैं. किसी कोई आरटीए का केस आया, वहाँ पर आपको ऑपरेट करना है पेशेंट को, लाइफ सेविंग है उसकी, बट यू डोंट हैव ब्लड इन ब्लड सेंटर और यू डोंट हैव एनी नियर बाय ब्लड सेंटर, देन those OTs can plan for the cell salvage. Okay, but preoperative autologous donation is something different. 5 to 6 days prior to the surgeries you have time. तो इसमें फिर आपने एलोजेनिक क्यों नहीं किया? You have time ना, you can arrange for the blood, but why autologous for this? One reason, another. Maybe the patient had multiple transfusions in the past, or maybe or at immunocompromised, maybe हर बार transfusion के time पे उसको कोई reaction होती हो. So in that case, you can go for preoperative autologous donation. Now ANH, that is acute normovolemic hemodilution. ANH is performed in the anesthetic room shortly after induction of the anesthesia. A large bore cannula is inserted to allow the collection of 15 to 20 ml kg of blood prior to the surgery. Blood volume is restored with the crystalloids and colloids. The collected blood is carefully labeled and same it is kept with the patient in the operating room. All times there is no need for the refrigeration. The blood is transfused back to the patient at the end of surgery once hemostasis is achieved. Now the conclusion. Autologous blood transfusion when used appropriately can provide a safe alternative to allogenic blood transfusion. However, there will always be a need for allogenic blood. There is an important need to balance use of resources in ensuring safe blood transfusion for all those who need it. Cell salvage is emerging as the preferred technique for the autologous transfusion, and an increasing amount of evidence is accumulating with respect to the efficacy and safety of the technique. However, PAD and ANH could be useful in rare blood groups and some elective high blood loss procedures. So, preferably cell salvage is considered, but when the patient is having multiple antibodies and no cross match is coming compatible, in those conditions we go for the another two methods. Now what about the transfusion reaction? Blood collection हो गया, blood preparation हो गया, blood transfusion हो गया, but there are the chances of reactions, right? How you define the reaction? Either the reaction occurs immediately or it can be delayed. Transfusion reactions are defined as the adverse events associated with the transfusion of whole blood or one of its components. These may range in severity from minor to life-threatening. A reaction may be difficult to diagnose as it can present with non-specific, often overlapping symptoms. Inappropriate decisions to transfuse put the patient at unnecessary risk of transfusion errors, reactions, and transfusion transmitted infections. The most common signs that indicate a person is experiencing an adverse reaction include fever, chills, hives, and itching. However, these symptoms can resolve with little or no treatment. Signs that indicate a more severe reaction include respiratory distress, hypotension, high fever, and hematuria. Hemovigilance is a program that monitors the reactions which occurs in the patient as well as the donor. All the blood banks in India are instructed to report the reactions to the hemovigilance. It is directly operated by the Ministry of Health. ये फॉर्म देखिए तुमने फॉर्म दे भी दिया उसको, कुछ समझ आया फॉर्म में? अच्छा, अब देख ले फिर एक्सप्लेन करना मेरे को. Whenever any patient gets the transfusion, you people want to go out of the class? You want to go out of the class? तो चुपचाप बैठे रहो, ठीक है? अभी जब क्वेश्चन पूछूंगी ना बेटा, ना हंसना आएगा ना बोलना आएगा। तब जब भी पेशेंट को कोई ट्रांसफ्यूजन रिएक्शन होती है, इट इज मैंडेटरी टू फिल दिस फॉर्म एंड रीसबमिट द फॉर्म टू द ब्लड सेंटर. In this form is clearly written about the details of the patient, the transfusion details like the bag number, the unit number, the blood group, at what time the transfusion was started, at what time it was completed. What is the significance of starting and ending point of the transfusion? Last class में बताया था ना, PRDC कितने आवर्स में ट्रांसफ्यूज हो जाना चाहिए? 4 hours, right? Platelets 30 minutes, FFP 30 minutes. अगर कोई ब्लड 11 o'clock इशू किया जाता है और उसका ट्रांसफ्यूजन स्टार्ट होता है 2 PM पर, तो देयर आर द ग्रेट चांसेस ऑफ द रिएक्शन. दैट्स व्हाई दीज आर द मॉनिटरिंग फॉर्म्स टू बी गिवन टू ऑल द पेशेंट्स एट द टाइम ऑफ ट्रांसफ्यूजन. What happens after the transfusion reaction takes place? कुछ करोगे पेशेंट का? What you will be doing? If you are posted in the ward, then what you people will be doing? Stop the transfusion. Then? हाँ? क्या? अच्छा, और
वो जो ब्लड आया ना, जो चढ़ाया और जो ट्रांसफ्यूज के दोनों के ब्लड को ब्लड बैंक मिलेगी, कंपैटिबिलिटी चेक करनी है.
कंपैटिबिलिटी तो पहले भी चेक होकर के इशू हुआ था.
अरे प्लस एरर है ना, प्लस भी एरर कर सकता है. अगर एबी पॉजिटिव है तो वो नेगेटिव लगा देंगे, वो भी चाहिए.
U4, leave the class right now. Get up. हमारे पास में अलग. निकलो क्लास से. रोल नंबर बताओ एंड लीव द क्लास. रोल नंबर बताओ एंड लीव द क्लास. हमें भी जाना है. Keep standing. Hardly matters. Then transfusion reaction जब होता है तो it is very important to understand whether the reaction was acute or the delayed. Delayed reactions are always and most of the time those are life-threatening. Acute reactions can occur in the form of fever, urticaria, itching. So you just stop the transfusion, monitor the patient, and if the patient vitals are stable, then you can start the transfusion again. But if the reaction is severe, then you resend the bag to the blood center along with the sample of the patient and the urine sample. Why you get the urine sample of the patient? To check for the hematuria. The classification of the transfusion reaction according to the time interval, they can be acute or delayed. Acute transfusion reaction, it is a transfusion reaction with signs or symptoms occurring during or shortly after the transfusion, that is within 24 hours of the transfusion. Delayed transfusion reaction occurs with signs or symptoms presenting more than after 24 hours, or it can be after 3 to 4 days also. According to the pathophysiology and mechanism, it can be infectious and non-infectious complications. Non-infectious complications of the transfusions are greater risk to the patient than the infectious diseases. Now the immune versus non-immune reactions. Next class में we will be discussing about the immune and non-immune reactions along with the patient management. Any doubt up to this?